Today's episode of the StallSide podcast was brought to you by Rood and Riddle Veterinary Pharmacy.
How you doing?
I'm good. How are you today?
I'm great, thanks. Yeah. So, interesting guest on the show this week.
Yes, we have a very skilled medicine clinician at our Saratoga practice who's going to take some time and spend with us today. Dr. SarahThomas, thrilled to have her with us.
Yeah, it's great. She's been a wonderful addition to the team. She actually came through the Lexington clinic earlier on in her career and spent some time with us, and we were so impressed that we were really happy to get her back from where she was.
Yeah, and she's like I said, she's doing a fabulous job for us up there, and excited to have her here.
Yeah, great. And so on StallSide this week, we're going to talk to Dr. SarahThomas, and she's going to talk to us about problems that occur in the foal in that sort of difficult age, as she describes it, from about 4 weeks on. Dr. Thomas, welcome to StallSide.
Thank you for having me.
Thanks for joining us today. Appreciate you taking the time. You're busy individual up there, and we're glad you are taking the time to be with us.
So, Sarah, tell us a bit about yourself.
So I have been up here at Saratoga doing internal medicine for coming on 3 years now. Have a little bit of a varied background. So I actually swore I wanted to do lameness when I was in vet school and did a lameness internship to start. Then realized the error of my ways, decided that I really liked critical care and emergency work. So I actually spent 2 years, close to 2 years, down in Lexington doing the medicine fellowship and the rotating internship. It was at that time that I really found that my passion lied more with neonates. Given that, I did a medicine residency at Texas A&M. Thought I wanted to stay in academia and did do kind of emergency medicine for a bit, but jumped at this job when it came available. And come late this summer, it's going to be my 3-year anniversary in Saratoga.
One thing I found about foals is they're either trying to kill me or themselves, and so it's not real pleasant. So I'm glad somebody really loves doing it.
Yeah, so tell us a bit about your time in Texas, because I always used to sort of rag on you and said you need to get some horns on the front of that Ford Escape you used to drive. You never did that, did you?
Yeah, I didn't. I did get a little sun visor that had a longhorn on it, but we did see quite a few longhorns and quite a few bucking stock. It was definitely an interesting experience. But, learned a lot by seeing some things I hadn't been exposed to before, seeing a fair amount of food animal work. But definitely also realized that horses are definitely my primary interest.
Yeah, and that's why we're really excited to have you on the show today, because, we've talked a lot about neonates, but today you're going to tell us a little bit about problems of foals when they get slightly older, out to about a month of age, because that's a completely different set of problems, and people think they get over the initial hurdle and everything's going to be okay, but sort of more or less towards Bart was saying before, they will find a way. So tell me what foals like to do at about a month of age, which takes them off the straight and narrow.
Yeah, so to me, I feel like the kind of hardest age group is that kind of 1 to 2 months of age, because I feel like in the neonates, you kind of know what you got, right? You've got the primary, got those foals that come in with a dummy gut or an ileus. You've got the septic foals, fed babies. But at that month of age, I feel like they're at this weird group where they're starting to get older foal problems, but still also occasionally have those younger foal problems. Realistically, the primary things I start to see in that age group are still colics and diarrheas, but trending more towards the rotaviruses and away from the clostridiums. And I start to see more pneumonias, not necessarily of septic origin, but of early rotacoccus cases, especially some years more than others. We start seeing those at 4 or 5 weeks. And also seeing cases of viral pneumonias and bacterial pneumonias. So I find it a very interesting age group to work on because of that, because they're a little less well-defined than, you see the 4-month-old with pneumonia. It's probably rotacoccus, but you see that month-old foal, you're kind of at the early age for that, but they're a little more of a puzzle to me. I would say the primary thing this year that we're seeing is less early rhodococcus. Our rhodococcus foals seem to be trending more towards the 2 or 3 months this year. I'm seeing a lot more slightly older foal colics and diarrheas. And a lot of those are either testing for rotavirus or not testing for anything, but improving with just supportive care and symptomatic treatment, likely of rotavirus origin that we just missed the testing window for.
So you mentioned that this is sort of an unusual age group because they can sort of be anything. What do you think's going on with those foals at that age that makes them sort of so susceptible to lots of things? Like, it's pretty obvious early on, right? They're just trying to get a start in life. But about a month of age, you should be able to sort of walk and chew gum at the same time. Why are these foals at this age such a problem? What do you think's going on with them that sets them up for trouble?
So one is there's a big change in their GI tract. So you have these foals who have been primarily existing on a milk diet, and they start to eat more of the mare's feed, eat more hay. They're really starting to turn more into that hindgut fermenter. And we do have some studies showing that microbiota changing from the time they're born to weaning. We don't have a super great understanding on exactly what factors in that microbiota create issues, but that it does seem to be associated with changes in their GI tract. In addition, I feel like that's the age where these foals are kind of getting out and exposed to more. So you see mares getting rebred, you see them moving farms, getting exposed more to some viral infections that though they can often tolerate those on their own, then they're getting secondary bacterial pneumonias, going into other herds where they might be exposed to things like rotavirus. So there's a lot going on in their life at that time of age where I feel like those neonates are kind of protected. We're not moving them around a lot. We're not exposing them to a lot. And that makes quite a big difference as well.
Yeah, that's probably a good thing. They're sort of at that, they're sort of at that stage where, they're getting out and about and they're sort of getting into trouble. You picked up on some GI things and what you're sort of seeing this year. What's your approach to the gastrointestinal upsets in foals of that age? Because diarrhea, right? Nobody wants it. So, what's your approach? Just like how do you do your exam? What diagnostics do you want to take? And how do you manage those foals in a sort of practical fashion to get them back on the mare as soon as possible?
So essentially, I do fecal testing, but in my mind, every foal should be approached the same no matter what, because we don't get that testing for 48 to 72 hours. And what that looks like for me is doing a good physical exam. Occasionally they come in quite painful, quite distended, and I do immediately check stomach size as being one of the most common reasons that a foal is quite painful on admit. So if it appears distended, appears colicky, I stop everything, pass the tube, check for reflux. Otherwise, a good physical exam. I do feel like those month-old foals are still at that age where systemic sepsis is fairly common if they have an enterocolitis. So looking at their membranes, looking at their sclera, looking at them for any joint inflammation, lameness, and doing a very complete ultrasound exam. I do feel like a lot of these foals might have a completely normal intestinal wall thickness and be horrifically sick and septic. However, it's good to know up front, is there evidence of something else going on? Because this is also the age group for things like small intestinal volvuluses and intussusceptions that, in my experience, a lot of them are due to a predisposing enterocolitis affecting their motility. So ruling those things out quickly, since those can be surgical emergencies. Evaluating blood work, we're lucky that most of our foals come in very early in disease. They're seen dumpy, they're seen with diarrhea, they come right in. So electrolyte abnormalities aren't a huge issue, but of course checking, do we need to replace some electrolytes? How dehydrated are they? Do they need any protein replacement? I do put all of my month-old diarrheas on broad-spectrum antibiotics, and I always feel like that's something that some younger veterinarians get confused by, because in adults, I don't. I often avoid antimicrobials in adult diarrheas. Going back to that microbiota, in my mind, a month-old foal is closer to a neonate. So I worry about sepsis, I worry about systemic infection, and I still worry about Clostridium. So I do get a catheter and do broad spectrum antibiotics. I'm also a strong believer in taking them off milk. So I do remove milk on those month-old foals, especially with rotavirus being so common in that age group. They do have a lot of villus destruction in their small intestine, which makes them have trouble digesting milk enzymes. And given that, I do see a great improvement by giving them a break from milk. If they want to eat hay and they're not colicky, I do typically provide that. And then I provide fluid therapy with calcium and other electrolytes, and also dextrose. I also like to use lidocaine in foals that are quite uncomfortable and do see quite an improvement, even more so, I would say, than adults in their comfort level with a lidocaine infusion.
Yeah, I mean, that's pretty comprehensive management for these foals because, as you say, they can be systemically pretty sick. And the other thing is, yeah, I mean, you identify they get bacteremic, right? You break that barrier in the bowel and away it goes. So that sort of plays on to the other thing that goes can go on. Pneumonia, right? I mean, and you always sort of wonder, you know, sometimes these foals come in a bit colicky, a bit diarrheic, and you find they got some pneumonia. As you say, it's probably too early for rotococcus. So what's your approach to these foals that actually have lung issues at that age? Because you're right, it can be a fairly unique subset because they're not necessarily old enough for rotococcus. And so you've got like a plethora of other things that can be involved. So how do you get to the bottom of those?
So in addition to, I do always ultrasound the lungs as part of their admit workup. If there are significant lung changes, I strongly encourage tracheal washes in all of my cases, especially if it is kind of early in the year and this is the first set of pneumonias that farm is seeing. So if they do happen to be like an early rotococcus, now we have a sensitivity that we can start to look at for what's going on the farm. And in my opinion, a tracheal wash is a very minimally invasive but high yield procedure so that once we get started on treatment, if it's not effective, the pneumonia is getting worse, or we need to pick a longer term option for discharge, we have that available within about 2 to 3 days.
Yeah, I mean, that makes a lot of sense because if you got one sick foal, you're going to get another sick foal, right? I mean, that's just that's just run of the rules, and so it's good to have that information early on. So other organisms besides rotococcus, what are you finding in your environment? Like we get a lot of strep zoos that can be really, really bad. Just to get a smattering of like Klebsiellas, E. coli, like even Bordetellas of all things. So what are you seeing up there?
Largely E. coli. So I would say, yes, fair number of streps, especially in our adults. I see a lot of, especially rotococcus foals up here with secondary E. coli infections. This year, not quite as significantly, but last year, quite a few that were very multi-drug resistant E. coli infections that we ended up treating with aggressive kind of nebulization as well before we started to see improvement. But that was something where I would say probably 75% of my foals last year that were in clinic grew with secondary E. coli on their pneumonia.
Wow. I mean, yeah, and that's, so do you think the ones with mixed infections, do you think they are more challenging clinically to get right than foals that just have like one organism? Do you think that makes it tougher?
Absolutely. I would say that several of these foals that we saw with these kind of multi-infections, we also saw quite a few that ended up with more of an interstitial pattern of pneumonia and were more distressed. Then the struggle is as you're trying to treat these infections with antibiotics that are different, right? You're going to treat an E. coli very differently than you're going to treat a rotococcus. You end up on a variety of medications that we would also see secondary diarrheas occur, mostly in our older 4 or 5 month old foals. But these foals were quite resistant to treatment and took long periods of time to get under control.
Yeah, you mentioned a word there that a lot of the audience may not be familiar with, interstitial. So tell me about interstitial pneumonia and sort of what we think might cause it and how it complicates things.
Interstitial pneumonia is something I always worry about, especially when I get a call of a foal that is severely tachypnic and panting for breath. It has a very special appearance on ultrasound where it almost looks like a kind of whiteout is what I tell the interns to think about it as. So not necessarily you see huge abscesses, but you can tell that the lung is just not moving air. And when you scan it, it almost looks like this bright white line of these comet tails kind of coming together. The issue with these foals is often what we believe is happening is it's almost like this overactive immune response. So it's not necessarily the bacteria itself, and it's not one particular disease that seems to cause it. Typically, when I see interstitial pneumonia, my top concerns are rhodococcus. Herpes virus can actually cause it in especially younger foals, E. coli, and streps. But I would say most of the ones I see are rhodococcus and or E. coli. And these foals can decline quite rapidly and be quite unresponsive to treatment. I often end up giving some fairly high doses of dexamethasone to get them under control. I would say a majority of the foals that I lose to pneumonia here are foals that go into acute interstitial pneumonia or acute respiratory distress syndrome or ARDS.
Yeah, so you mentioned about using dexamethasone on these foals, but I mean, they're pretty intense cases. So hospital-wise, what do you need to do to these in a hospitalized situation that's going to be really difficult to do in a farm situation?
So these foals are on oxygen at this point in time and are quite oxygen dependent. And in addition, I do quite a bit of nebulizing on these foals, which some of our farms have started to do as well. But I'm often not only giving them oxygen, but nebulizing them with things like fluticasone, which is an inhaled steroid that helps reduce the use of systemic steroids, antibiotics, and if they have a lot of mucus in their airway, acetylcysteine to break that up and help with delivery of medications. So I might have these foals getting nebulized every 4 to 6 hours in addition to very aggressive oxygen therapy via nasal cannula. So we do have these foals hooked up to continuous oxygen while they're in the hospital.
Yeah, what about the environment itself? You find cold air is useful on these?
Yes, they can be very difficult to manage in heat, and you can see a significant difference. So, for example, one of our barns does have some air conditioning, and if I move them into that, you almost see an immediate improvement. It's the same thing with adult pneumonias, where often just getting them out of the heat can make a big difference. The other thing is some of the antibiotics that we use, so say this is a rhodococcus case on a macrolide, can make them very sensitive to heat as well, which further compounds the issue. So definitely the availability of air conditioning in addition to the oxygen is quite useful.
Yeah, so you believe in clipping these foals?
Luckily, our weather is not quite as bad as it is down there as far as we typically have cooler days. So I have done it, but so far we've been able to keep them fairly cool with fans and shade. Definitely when you're to that point of this foal needs something, I have clipped them before.
Yeah. So once these foals are out mingling and they're on pasture, they're going to come across something else. They're going to come across the first gastrointestinal parasites that they're ever going to see. So what's your take on what's going on there, and how do you help people through that period?
And in that regard, I think it's very important to have all of your foals on a good deworming program, largely because they're being exposed, they're immune, they're very naive to parasites at that point in time. And unfortunately, what we see a fair amount is it kind of gets forgotten. And then all of a sudden, as the foals get older, and I would say closer to 3-4 months of age, they get a very large parasite burden. And now they look a little wormy. Maybe we better deworm them. And they get a fast kill product. And that's where we do end up seeing some of these foals get into trouble with ascarid impactions and other issues. And the problem with that is the parasites themselves can actually create such a severe obstruction that it becomes a surgical lesion. However, the inflammation associated with those parasites and trying to resolve it has a very poor prognosis associated with a problem that could be avoided by keeping up with parasite control early on in the foal's life.
Yeah, that's a really important point because you get them up there, we get them down here as well. We get these ascarid impactions. Foal comes in, colicking, the ultrasound looks terrible, and then you start to sort of see cross sections of parasites in the lumen, and you pass the tube on these foals, and you're refluxing ascarids out, and there's that many in there, and so it becomes a surgical emergency. And I'm totally with you. If you're ever in the situation, you open those foals up, the gut is so inflamed. There's little hemorrhages everywhere. They can really develop a severe thromboembolic problem afterwards and throw clots, and they just don't do well. So I'm totally with you on that one. I mean, it probably seems a strange thing for people to try to get their head around. What do you mean this foal's just gone out on pasture? How can it have parasites? But if it doesn't have them now, it's one mouthful away from getting them. And away it goes, and there's just no way you can escape that burden. I mean, you'd have that same problem on the farms you've dealt with too. But
one thing I would say that is important to remember is that we've got resistance build up in a lot of our horses, so it's important to know what's working and what's not working in particular regions and even specific farms. So doing those fecal egg counts as you go along and doing them post deworming is important because most people are rotating through dewormers, and then as Sarah said, you could use one, think you're doing a good job, use one, but if it's totally ineffective, and then 2 months later you use a different one, and it just annihilates your parasite load, then you've caused the same problem as not deworming and then deworming later.
Yeah, and that's the issue when farms finally have one of those problems you talked about, those ascarid impactions. They want to go out and they just want to nuke the area. They just want to say, well, what can I do to treat all my foals? And then you have to sort of say, well, hold on. I mean, if everybody dies and tries to head for the exit at the same time, we're going to have like a huge problem. So it is a really difficult conversation sometimes to say, yes, I know this is a problem we need to deal with, but we don't know how many foals are out there with a burden sufficient to create an impaction if we start to kill everything off at once. So that really does become a difficult conversation. Yeah, and so the management of those foals, right? How do you manage those in that situation? How do you say you have this severe worm burden? How do we actually approach the individual? What hospitalized treatment does it need that's specialized, and how do we approach the herd in that situation?
So as far as the herds, when I've had foals come in with severe burdens in the farms kind of in panic mode, I think fecal egg counts aren't wrong, but I also do warn them that fecal egg counts aren't always a good indicator of how severe the parasite burden is. So I do encourage them to use a slow kill protocol on the other foals that were housed with that foal concurrently in order to be the safest possible, and then reevaluate for the younger foals and for future years, what are we doing with our deworming program that we could prevent this from happening in the future. But I agree with you. I feel like often the response is, well, I'm going to go home, I'm going to deworm every foal on the property and take care of these parasites, and then they end up having more occur. We have had some foals that come in for colic, and we've discovered large numbers of ascarids that weren't associated with the colic episode. And same thing, I keep those foals in hospital. I do give slow kill products to make sure they're monitored. And I've had some clients say, well, why don't you just open them up and take all of the parasites out? But again, the degree of inflammation associated with trying to dump the parasites out of the GI tract at surgery, in my opinion, is just not worth it. So we really focus on what do we do for the foals that are currently in the field with this foal, but how can we make this not happen in the future?
No, exactly right. You don't want to. You do not want to crack one of these foals open. If you do, you're actually backed into the corner because there's just no other option. So yeah, I agree with you totally there. Any other problems at that age of foal that you'd like to talk about?
Something that's just kind of associated with all of these problems is, of course, the gastric ulcer concerns. And I would say whether it's pneumonia or GI related, if I have a foal in the hospital, I'm very aggressive about management for ulcers and do put them on multimodal therapy in that regard, and encourage farms who are managing them at the farm, if they're on stall rest, if they're on medications, to continue treating them. Because I would say the last thing we commonly see these foals for are ulcer problems.
Yeah, and that's a point we were talking about that before, is that, foals get to the point, and you mentioned about obstructions and that, and that can be a very difficult thing to get past once it actually becomes serious. So yeah, mother was right. Ounce of prevention, pound of cure.
Yeah.
Mother was always right.
Well, one other problem that we have that's associated with all of this, and it falls a little bit out of your area of treatment, is septic joints. But it's a little bit hard to explain to clients when they've had a healthy foal for 30 days that's doing just fine, and all of a sudden it pops up and it's got a septic joint and a bone lesion. How is that happening?
How I kind of explain it to people is at some point there has been an infection that has seeded into that joint. At that age of foal, we see a fair number of rhodococcus-associated ones. Anything that comes in that is apparently healthy with a septic joint, I encourage we do a full workup on it. So we often scan its abdomen, scan its chest. Not so much at that age, but definitely slightly younger, scanning their umbilicus. And evaluating for, is there a site where this infection could have come from? And I would say a majority of the time we find something, whether like these rhodococcus joints, we do end up finding pulmonary abscesses, or honestly, last year we had a lot of abdominal abscesses occurring in our population. Otherwise, you have to suspect that at some point there was some type of bacteremia that was associated that led to infection of that joint. And we do treat those foals systemically in addition to treating the joint itself.
Yeah, I'd vote with Sarah on that one. Like diarrhea foals, you said before that you put them on broad-spectrum antibacterials, and I totally agree with that. Even though it doesn't look like you're treating anything, you're preventing stuff, because you get that bowel inflamed, you break the barrier, they get some bacteria in there, and they just go and they just sit and they wait their time and they blow up. And the other thing is, I've had foals at that age group that have had urachal issues. When you actually look, they've got urachal abscess, or maybe even the umbilical vein going up into the liver. Sometimes you'll find like a focus sitting there that hadn't caused a problem, and it just like sent enough out, seeded a joint, and away it went. And so you just cannot be too careful. But I absolutely am on Team Sarah on putting these foals on broad spectrum antibacterials. I mean, older foals and adults, you probably don't have to worry, but that month age group, you get them through everything else, and then they have a joint or a physis blow up. I mean, you've done your chips.
Yeah, and I would argue a lot of these sick foals, we can get them through the diarrhea, we can get them through a lot of the more mild to moderate pneumonias, and those secondary issues like joints and gastric ulcers leading to obstructions that we end up actually losing the foal to, often not even the primary problem.
Yeah, I mean, agree with that. And I think people sometimes have trouble when they look at how comprehensive your treatment plan is to sort of say, why are you doing all these other things when I'm here for this problem? And by bitter experience, I think we've all come to realize that you just hit the nail on the head. It's not what you're dealing with today. It's what that's setting in motion tomorrow that you don't realize yet. And we can get ahead of those things by trying to, as you say, cover the ulcers, especially because there's nothing more frustrating than getting a foal over a bad diarrhea or a bad pneumonia situation and then having that teeth grinding, and then they're obstructed, and then we got a whole different problem that's serious. Great. Well,
okay. Well, good discussion.
Yeah. I mean, that's going to, I think, hopefully cause a lot of people to go out in the paddock and have a look at their month-olds and start thinking about what might be going on. But you don't want to worry anybody, but on the other side, you need to make them aware, because you hit the nail, and that's an age group when they're at a lot of risk. They've transitioned from a milk-fed foal to something that has to eat pasture, or at least steal as much of the mare's feed as possible. They're out there with their own kind, swapping bacteria and viruses, and there's a whole sort of smorgasbord of parasites awaiting for them on the pasture, and so it's a dangerous age.
It is.
Yeah. Well, Sarah, we can't thank you enough for being on StallSide. This has been a great chat.
Well, thank you for having me.
Yeah, that's been great. And so, I mean, that was StallSide for this week. We've been talking to Dr. SarahThomas from our clinic in Saratoga about foals at approximately 1 month of age and all the problems that they can have that you need to be aware of. See you next time.